But what we can't do is promise that there will be no consequence and no delay, no further suffering, because there are lots of people whose procedures are scheduled over that weekend period, and in the period subsequently where the NHS has to recover from the industrial action, who will see their operations and appointments delayed. I have a relative in that position. My family are currently dreading what I fear is an inevitable phone call saying that there is going to be a delay to this procedure, and I just think this is an unconscionable thing to do to the public, not least given the 28.9% pay rise. The other thing that I have found actually shockingly irresponsible about the BMA's position is their leaders seem to be telling their members not to inform their trusts or their employers if they're going out on strike. Now, I might not agree with the BMA's strike action, but I do accept they have a right to strike. I do accept they've followed the rules in order to go on strike. What I cannot fathom is how any doctor in good conscience would make it harder for managers to make sure we have safe staffing levels, would make it harder for other staff who are going to be turning up to work that day, not least the staff who have not had a higher percentage pay rise, many of whom are paid less than resident doctors. So I just think the sort of the BMA's approach to this from start to finish has been completely wrong. They started off a year ago with an incoming government that had an enormous amount of goodwill towards them, an enormous amount of sympathy for the arguments they were making, and worked quickly to resolve those strikes. And not just a deal to end those strikes, but the opening up of a partnership where we could work together to improve the NHS. And instead of working in partnership, they've chosen confrontation. It's not too late, even at this late stage, for us to get back on the path I wanted us to be on, of working together, of driving real improvements for resident doctors and for patients, but it is going to require a different mindset. The government's changed, the policy's changed, it's time for the BMA's tactics to change, and the idea that doctors would go on strike without informing their employer, not allowing planning for safe staffing, I think is unconscionable, and I would urge resident doctors who are taking part in strike actions to do the right things. I'm sure many of them will. Jim?
I better just check with the chair, because I'm out of my lot of time, Jim.
No, you've got another 51, 52.
Bring Jim in then on that one.
Yeah, so just to add to that, I lived through this as a trust chief exec, in the last few rounds of it. It's first of all, to reiterate what Secretary of State said, everybody respects the right to strike, but this is hugely disruptive, much more disruptive than we've been able to describe so far. I've worked with all the consultant colleagues at the end of a week when they've been working very, very long hours through the night to keep the service going. I've met with families who've had diagnostic processes cancelled 3 or 4 times because of strikes. And a lot of this narrow definition about what's technically necessary, I don't accept. It's not that straightforward, and we won't be accepting that kind of process this time. So really hope that this is avoidable. But we also can't allow this to play out in the way that it did last time, with a huge impact on people's lives, colleagues working in the service, a cancellation and a disruption of clinical pathways that is very hard to quantify the impact on. So I would just say, let's not just get too focused on the impact on the elective list. There's a whole range of other disruption that comes with this that we must avoid at all costs.
Thank you.
Thank you, and thank you for that line of questioning. Can I move swiftly over to Greg, please?
Thank you very much, Madam Chairman, and good afternoon, Secretary of State. Unfortunately, I shall be continuing some of the line of the questioning. Can I characterise your view, therefore, on the strikes, that the strikes prior to the general election were reasonable, whereas the ones after the general election were unreasonable? Just a yes or no.
Well, I felt that the previous government was unreasonable by refusing to sit down and negotiate with the BMA for extended periods of time. Yes? I think the strikes before the general election were avoidable.
So what do you think has changed with the BMA to change them from a reasonable organisation to an unreasonable one? I suppose what I'm saying is, what have you done or not done?
Oh, I didn't say the BMA were entirely reasonable throughout the entire period.
Well, what have you done? What have you done?
Keeping with their history, but
what have you done or not done, Secretary of State, that has made them come to this point of view?
Well, look, as far as I'm concerned, we've done the right thing. We came in, the strikes have been ongoing for a considerable period of time, at great cost to the taxpayer and at great cost to patients. We recognise the arguments that they've been making about pay erosion and about the conditions that resident doctors were working in, and we recognised the pressure they were feeling as doctors at a particularly early stage in their careers. And so I was proud of the deal that we did last year, proud of the decision we took again this year to implement the recommendation of the pay review body. Taken together, that's a 28.9% pay increase. And I would have expected, not unreasonably, that the BMA and resident doctors would think, okay, we might not have got everything we asked for, but we've moved considerably in the right direction, and this is a government we can do business with, as other trade unions do. We are, in the Labour Party, we're used to dealing with trade unions. Our history is anchored in the trade union movement, and we don't always agree with trade unions, even those affiliated with the Labour Party, but we do understand the value of trade unionism and the importance of deals and bargaining. But I don't see a reasonable kind of trade union partner in the RDC section of the BMA at this time, and I hope
but isn't that
will
part
change.
of the problem, Secretary of State? Isn't the problem that you gave them a massively inflation-busting pay rise, you asked no increase in productivity or efficiency from them, so essentially they've just come back for more? Do you accept no responsibility whatsoever for the position we're now in?
Well, firstly, I don't hold resident doctors responsible for the sort of productivity challenges we have in the NHS. I think actually there are many aspects of the way that they are treated at work which are fundamentally unproductive. So I don't regret the deal that we struck with resident doctors. I do regret that they are in danger of squandering the opportunity of partnership in favour of a more adversarial approach, which is unnecessary, and I fear will prove self-defeating, because if these strikes go ahead, with the financial costs that are entailed, not to mention the misery inflicted on patients, we have to find that money from somewhere, and that will come at the expense of things that they value. I
think you've made that point clearly, Secretary, and I think I suggest we all agree with that point of view. In December 2023, you noted that the then government was giving a higher pay rise to doctors than it was to nurses, and you said it was, and I quote, completely wrong, a slap in the face to nurses, and it seems to me fundamentally unfair. So if the nurses went on strike, would they be being reasonable or unreasonable?
Well, I hope that we're not going to get to that position with nurses, not least because we do have a reasonable dialogue and relationship with the Royal College of Nursing, Unison, and others in the agenda for change.
I hope we don't get there either, but if we do get there, Secretary of State, would they be being reasonable or unreasonable, given your own previous comments on this issue?
Well, we're working with those unions on agenda for change, pay structure reform. That's what we've agreed to do. I think so long as we fulfil our end of the bargain, then everyone will be happy and we can move forward building on that progress. If this government breaks its commitment to nurses and agenda for change staff, I think they would be rightly and justifiably angry, which is why we're not going to do that.
So, given that, as we heard in front of this committee some months ago from the then CFO of NHS England, most of the amount of money that's been put in this last budget was eaten up by pay rises, inflation, drug costs, etc., and therefore there isn't a vast amount of money left. Will you commit to having no above inflation increases to any health staff during this Parliament?
Well, we firstly have an independent pay review body process. I think that process is working largely well. I recognise that trade unions have a number of criticism about the way the process works, and I'm always happy to talk to them about how the process could be better. I thought, for example, the criticism that the PRBs reported far too late in the year was not just frustration felt by unions, but felt by me too, which is why
I suppose what I'm trying to get to, Secretary of State, is what your view on this is. I mean, I understand the processes, but what's your view? Do you think the public sector NHS staff should get an above inflation increase over the next few years or not?
Well, we always take into account the recommendations of the pay review body. What I would say to NHS staff is the best way for us to be able to deal with the pay erosion they've suffered over many years, and to make sure that we have a competitive rate of pay for NHS staff and a decent standard of living for all of our staff, is to make sure that on reform and productivity we're going as hard and as fast as we can. And that's why we've had to make some decisions on things like the abolition of NHS England, and bringing ICBs and systems back to balance, which at the moment are causing considerable pain for people involved in that decision-making process. And anxiety,
I don't need to cut
but
you
that's
off,
why we have
cut you
to
off,
make some of those
a
choices.
small amount of time. I want to ask you about one other subject. So the DASI report, the EU Commission said the dire state of social care is among the reasons that the NHS is in a critical condition, and you said at the Labour Party conference there is no solution to the crisis in the NHS that doesn't include a solution for social care. So why has there been really pretty much no inclusion of social care in this 10-year plan?
I don't quite accept that characterisation. So social care features insofar as it impacts on the NHS. So we would envisage social care being part of the neighbourhood health ecosystem. Much of the care delivered in people's homes will involve partnership with social care. In fact, we want to upskill the social care workforce to be able to undertake certain health tasks that we think under proper training they could undertake, would have to be supported with better pay. Delayed discharges, really big role for social care to play, and I would expect NHS organisations to look, when commissioning intermediate care accommodation for admission avoidance and accelerated discharge, that we'd be buying more capacity with and through social care. So that's how social care features in the 10-year plan. But of course there is a Casey Commission. Report 1 is out next year, and then the second report will be out subsequent to that to set out the long-term direction.
Well, that nicely brings me on to the Age UK, what Age UK have said, and they say delaying the process of comprehensive social care reform will only make it harder to restore the NHS back to health in this Parliament or even the next. Don't you accept, as Age UK seem to be suggesting, that kicking social care to the end of this Parliament by increasing national insurance contributions on the vast proportion of the social care sector is actually hindering social care and therefore will have an impact on how deliverable your 10-year plan is?
Well, I don't agree with kick the can down. Since coming into government, and we've only been in a year, we have increased the spending power in social care significantly. We have delivered the biggest expansion of the carers allowance since the 1970s, a big increase in the disabled facilities grant. We've legislated for fair pay agreements. The Deputy Prime Minister and I will be setting out shortly how they will work in practice and how we're going to roll them out. So that's quite major improvement. I'm not pretending for a moment it's a panacea. I'm not pretending for a moment it's a panacea, but those are meaningful, demonstrable steps in the right direction, and there is more to come.
I will. I'll leave it there because I'm sure the chair wants to come in. Final question from me. I have a number of health-related concerns within my constituency of Farnham and Borden. Will you be willing to come and meet some of the doctors and patients in my constituency to hear their concerns?
If the diary allows.
I'll take that as a maybe. Thank you very much, Chairman.
Not that in there, Jeff. Okay, over to you, Ben. Thank you, Jeff, for your line of questioning.
Secretary
over
of State, Secretary of State and Jim and Sally, thank you very much for coming today. And it's just been a fascinating read, and also a nice read in large print, which makes a change. The separate government document actually makes it easier to read. I just want to talk a little bit about equality, and particularly race inequalities and inequity as well, which of course is different from inequality. It's excellent that the 10-year plan references inequalities and to see the determination to improve matters there. But it says relatively little when it comes to ethnic or race inequalities. And you'll be aware that we've been looking at this as a committee. The work we've been doing on maternal health, it shows quite serious differences. More black women die in childbirth, as the 10-year health plan references. More black children die in childbirth, at least twice as many. There are lots of examples of that. Do you think that there should be more in the implementation plan which you're bringing out about tackling racial inequality, particularly structural racism in the NHS, than there is in the 10-year plan itself?
Yes, I mean, I think unfortunately this is a huge issue in the NHS at every level. If you look at the experiences of Black and Asian staff, if you look at the experiences of Black and Asian patients, even adjusting for class inequalities and social determinants, we are seeing unequal outcomes for patients. We're seeing bullying of staff, which actually, when you think about how long we've had Black and Asian staff in the NHS since the beginning of the NHS, I think it's just completely intolerable. We don't have enough Black and Asian faces around executive and non-executive boards across the NHS, and that culture flows right down. In the work that I've been doing on maternity, obviously the Black maternal mortality gap has been well publicised, and should be no less shocking to us now than the fact we've become used to those statistics. But what I was really, really shocked by, talking to some of the victims of NHS maternity scandals, were the patients who described, and patients and survivors, I should say, being described as a kind of a problem. One woman told me that she had been told, well, I thought you were a strong Black woman, as an excuse for the fact she hadn't received enough pain relief. Yep. Asian women described as divas. And so, yes, there are health inequalities that need to be tackled, and some of that is about public policy, some of it is about social determinants, and the sort of the wider inequalities and things like genetics, disposition to certain disease and all the rest of it. We've got to deal with that using good science and good quality care, but that does not explain just the overt as well as unintended or unconscious racism that we see in the NHS.
So given that, and it's very interesting you talk about within the NHS, and I've been looking at the figures for the staff surveys which are published for 150 NHS organisations over the last few years. And it is quite shocking because the figures for 2022 on whether you feel that you have had fair career progression, whether you've been discriminated against by patients, whether you've actually, or other members of the public, whether you've been discriminated against by other members of staff, have actually got worse in the last 2 years. Jim, is this something you recognise and something that you have ideas about how you want to tackle it?
Yeah, absolutely. So this will be something we really want to elevate in this next phase. So from a staff satisfaction perspective, but also patient satisfaction perspective, and try to get behind these metrics and really understand what's driving concerns and how people feel like they're treated.
Do you think, given the fact that the figures have got a little bit worse over the last 2 years, and actually all the time I've been looking at it, which over a number of years, they get a little bit worse each year, do you think the NHS doesn't have an idea how to tackle it? And if you do, what would you think it could do differently?
I think pockets of the NHS have. I think there is evidence where organisations have been very systematic about understanding the data, really tailoring that to local actions that really address the specific issues there. There is evidence that has worked. It hasn't worked absolutely across the board, and we will absolutely be trying to do that and scale that across the NHS.
Yeah, I see. So I'm sorry, Wes, forgive me. I saw Sally nodding vigorously there. I just thought maybe she could come in.
Yeah, thank you. So I think particularly when it comes to workforce race equality, there's really good examples where local trusts have tackled and made improvements on 2 or 3 metrics, but they've not been able to shift that to improvement across all of the metrics. So I think there's a task for us nationally to help share best practice. Some of that's about networks, some of it's about leadership programs. So that there's lots of activity that has been proven to work. It's just about how do we scale that across all of our local trusts.
And I was just going to add briefly, this is where I think we need to reform our approach to diversity, equality and inclusion. There's a kind of school of thought that says anything that's spent on DEI is sort of like dead weight costs, wasteful, get it out of the NHS. Actually, as we can see through the Black maternal mortality gap, or you can see in other areas like mental health, inequality can be a matter of life and death, and it should be the NHS's core business to tackle health inequalities. I think, therefore, we both need to reform our approach to equality, diversity and inclusion within the NHS, and also hold people to account for outcomes. not just inputs and workshops and posters and all manner of other things that people are doing, because it should not be the case in this decade of the 21st century that black women are 3 or 4 times more likely to die in childbirth than white women, or black men are twice as likely to die of prostate cancer than white men.
Absolutely, and obviously it is just simply wrong, it is cruel, it is poor, it's also expensive. And I wondered if this is an area which the NHS RHO has been looking at, the Race and Health Observatory has been looking at, but they've been looking at the cost, the economic cost of racism. And for example, in maternity care, if you get women dying 3 times, you get £1.6 billion compensation is paid out for maternity-related cases every year. In mental health, where black men are 3 times as likely to be detained under the Mental Health Act, or say 8 times as likely to get a community treatment order, they will cost the NHS, this will cost the NHS some £11,000 to £12,000 a year. A white person's costing £5,000 a year. I don't think it's intrinsically the colour of the skin that makes people behave differently. I think it's the way that people are treated that's costing the NHS a lot of money. The workforce, bullying and harassment costs £2.3 billion a year, huge amount of money. Again, it's a particular risk if you're a black and minority ethnic background. There's all sorts of other areas. So the idea of taking what the NHS 10-year plan says about allocating NHS money more effectively to better maximise, split infinity, but it's in the paper, to better maximise return, is part of maximising your return better, doing a proper cost analysis of the economic cost of structural racism in the NHS.
Yes, I'd also say, because I think sometimes when you illustrate the cost to the economy as a whole, that can be really helpful in terms of elevating something as a priority and kind of demonstrating the impact that it would have if we solved X problem on the cost to the economy. But I think even more powerfully in an NHS context, we can kind of demonstrate the actual cash price of failure. You just did it in maternity. I mean, it is shocking that we're spending more on maternity claims than we are on maternity service improvements. It's kind of no-brainer to me that we need to shift a number of these things in the right direction, not least because it's better value for money, but most importantly of all, because everyone in our country, whoever they are, whatever their background, deserves access to high quality, safe care where they feel safe and respected. That should be a service that is available to everyone, and the people working in the service should also feel that they are able to bring themselves, their whole selves, to work, and that they should not be discriminated against because of who they are.
So you'll be looking at the actual costs that you could save at the same time by not just dealing with racism because it's iniquitous, and no matter what other parties on the right of us say about not doing diversity issues, it's clearly highly inefficient because it costs the NHS a lot of money, taking a very stark view at a time when we have been left with empty cupboards wherever we look. Just talking about the Cahill deprivation formula, and you're going to have another look at that, and that could lead to a different approach towards deprivation. Is that going to be on the basis of geographical deprivation? Are you also going to take racial issues into account, some of the challenges facing ethnic minorities, obviously who often come from poorer communities and are spread around the country, not just in specific areas? So will race equity be part of your Cahill review?
Well, we're going to consult on Cahill, and I think it would be a reasonable thing for people to ask us to look at, and we'll take that into consideration.
Will you take that into consideration?
The real thing we're driving at is to make sure that the level of resource going into general practice is able to meet the needs of the local population. And so you've got to take into account a whole range of demographic pressures and societal conditions on the health need and demand, Sally.
Yeah. So we've also said we're going to ask the Advisory Committee on Resource Allocation to look again at our overall formulas for allocations to integrated care boards, and we want to look there at a whole host of factors that can drive health needs. So some of that will be geography, some of it will be economic circumstances, but there will be a lot around coastal communities, for example. We know there's higher health need, we know that there'll be different health need from different ethnic communities, so we want to look at the best possible evidence base to then have a new formula that reflects current and future need for health.
No doubt we can come back and discuss whether we think your approach is right and it's a necessary thing. Final quick question, slightly different thing, neighbourhoods. Question about who's going to lead these locally. It could be GPs, it could be hospitals, it could be NHS trusts, it could be Private companies? Yes? All those are possibilities?
In terms of neighbourhood health services, we would anticipate these would be mainly NHS organisations, but you could imagine, with some of the things that we want to achieve, that we'll be working with people like Boots and Specsavers to deliver a greater range of services as well.
But led by NHS?
Yeah, always led by the NHS.
And that's going to require extra resource for whoever's doing it. It's quite a management job, running a neighbourhood health service. Is there going to be extra resource given to whoever's actually managing it, whichever part of the NHS they're doing it from? Or are they going to be expected to manage it and set up these new neighbourhood centres within the existing budgets?
Well, I think there's two different things. There's neighbourhood health, and in terms of leadership of kind of the needs of the local population, and then there's neighbourhood health centres. So in terms of neighbourhood health models, of course, with any new provider organisation, they'd obviously be commissioned and established with a level of management resource to be able to undertake the duties that they're taking on. Neighbourhood health centres, we have done two things. One is we've got the largest capital allocation the NHS has ever had. That gets us some of the way in terms of meeting the capital needs and pressures on the NHS, but we need to go further. The Darcy Commission identified, I think, undercapitalisation about £37 billion with the best will in the world, and even if the Chancellor is able to find more public resources available for us, I don't think we can anticipate over the course of this spending review or over the course of this Parliament that it would be sufficient to deal with all of that undercapitalisation that Darcy diagnosed. So we do need to look at alternative private investment options. That was in the government's infrastructure plan as far as neighbourhood health is concerned. We are treading cautiously. Proud though I am of the record of the last Labour government and what it did to waiting times and patient satisfaction. PFI led to large costs and in some cases very poor value. And
very poor contract management. We need to improve contract management.
Contract management.
Thank you very much.
Thank you. So we need to make sure we learn those lessons and get this absolutely right, Jim.
And just to add on that, from a management leadership point of view, what we've been trying to do, as Secretary of State said, is shift the leadership focus up through the chain into the centre and more local. So there's maybe some additional management resource short term to help develop neighbourhoods, but the idea is it'll be more productive management time over time spent locally rather than through an oversight and assurance process.
Thank you for that, and thank you for that, Ben. Can I hand swiftly over to Danny, please?
Thank you very much. Thank you, Secretary of State. Just to follow up on that question, I was going to ask about capital spending in the health service and as part of the 10-year plan. In terms of the NHS neighbourhood hubs, will there be any specific capital investment to enable the rollout of neighbourhood hubs, or is this solely leaning on future?
Yeah, we've committed during this Parliament to sort of 40 to 50 neighbourhood health centres. We think we can roll out during that period. If we are able to leverage in more external investment, then obviously our capability and capacity to do more is better.
Without private sector investment, the 40 to 50?
Yep.
Fantastic. And there'll be specific capital funding available centrally to enable, when would just be local systems under them. That's helpful. And in the PPPs, learning the lessons of PFIs, you've touched upon it slightly. What will be the kind of assurance process of local agreements? Will the department provide kind of very clear guidance to avoid the contracting mistakes that we saw under PFI?
Yes, so we'll be setting out some clear rules and frameworks that people can work within, specifically addressing the issues from the past and over time, model contracts, model approaches, those sorts of things. So we don't replicate things all of the time, but that will be something that will be developed over the summer. Also, just in addition, as well as PPP or traditional capital, what a lot of people are finding is there's a really good council facility, or there's an already quite new health centre that could be reallocated and redeveloped as part of this thing. So what we want to try and do is nurture all of these things at the same time, as long as it delivers on the principles and the outcomes we expect.
Well, thank you. And the plan talks about private financing of revenue generating assets, so car parks, other kind of facilities, energy facilities. will we expect increasing patient charges for car parks, for food, for other associated goods to enable this capital investment?
Shouldn't expect that.
So you're kind of confident that patient charging through these other routes
We'll
won't
not
be
be seeking
significant?
to shift the cost of this onto patients, but this is a really important thing to open up. There's an awful lot of commercial appetite out there in the NHS for the development of, say, pharmaceutical production or laundry services. One of the things that was being explored in the northeast before I came to do this job. So there's an awful lot of stuff there where there's a potential market opportunity. Was previously constrained under the old rules and now is possible under these rules.
Thank you. And so we've seen strategic health authorities and PCTs become CCGs and ICSs, then ICBs. Now we've got ICBs kind of light plus ICOs. Do you think the structures are suitably different to drive different outcomes? Do you think the fundamental issues about financial flows and incentives to prevention are significant enough? Do you feel the role of public health and social care are strong enough in the new structures?
Yeah, I do. I'm happy to.
So I think throughout this discussion we've come back through history at various points when we've tried some of this in different ways and it's either worked or hasn't worked or worked for short periods. There are really strong common principles. The use of the financial incentives, a devolved system, clear rules-based system, but also the clarity that you have to work with local partners, whoever those local partners are, and sometimes there's a really strong voluntary sector or independent sector, or you've got a specific housing issue or social justice issue.
There's always public health and there's always social care. What would make them work?
They should absolutely be at the table and be really key partners in all of this. The extent to which
different to PCTs, then ICBs through ICPs. Is that different?
So in some of those previous incarnations, the involvement meant representation on a board or in some form of governance system. What we're trying to say here is work with partners actively. Don't just address it in the governance system.
Because
sorry?
That sounds quite similar to person on a board to me. How will it look different to a person on a board?
I'm talking about operational, clinical, social care colleagues, practical people on the ground working within a set of rules.
They will have to work together operationally and in terms of...
It's about working at every level and my point is it's not done when you've appointed somebody into a board. This has got to work right the way through the system and be less bothered about who works for who, but more about what they're delivering for people.
And I want to see, in terms of the development of neighbourhood kind of health and care plans, I want to see people working together to develop those plans and sign them off together in a spirit of partnership, because I think it's fair to say, and having sat in different parts of this system over the years, the NHS always feels like the big beast at the table. Some NHS organisations are better at partnering with their voluntary and sector and their local government partners than others, but it should be like close working, mutual respect and partnership should be the norm, not the exception.
I certainly agree with that. In terms of patient power payments on financial incentives, what would stop under patient power payments sync hospitals developing or sync services which are already struggling financially? Patients then move their care or seek to move their patient power payment to bigger trusts, more successful trusts. How does that go kind of with the spirit of ensuring areas of deprivation get better services, not worse services?
So the first thing to say is we're going to trial this approach initially because it's never been done before, and on something like this, I wouldn't want to just roll this out across the NHS without making sure there aren't unintended consequences. But the purpose behind it is to give the patient real bite in the system. At the moment, it is extremely easy to dismiss and ignore patient complaints and concerns. And I've seen that in the most egregious cases of families who've been failed in the most appalling way in maternity services, in mental health services. I've spent a lot of time in the last year meeting with people I would characterise as victims of the NHS. Now, that's...
Is a payment, sorry to interrupt, because the time's short,
Yeah.
Is a payment penalty enough to change that, or is it a change of leadership, a change of culture, investment?
Well, I think
in those
ultimately, in
things?
terms of performance improvement, it's a range of levers and it's a range of consequences.
You guarantee that there won't be sink hospitals and sink services that see their funding just slashed further, or they're struggling potentially in maternity services?
But the money isn't pulled all away completely. It will go into a sort of patient improvement fund, and everyone from ICBs to NHS regions have oversight of services and financial performance, as well as quality and safety. So there are checks and balances in place. But what this will enable us to do, if it works as I intend, will be for patients to hit NHS providers where it hurts, because money talks in this system. And in doing so, that will send a signal up to us if we're spotting a whole number of patients in a particular part of the country are exercising that right to withhold payment for a particular service and put it into a more general pot. I must say that's not my big fear with this system. My fear is that it'll be a bit like someone who gets a ropey Uber driver who's taken them round the wrong route, but thinks, well, if I give them anything less than 5 stars, I'm going to get them in trouble, so it gives them a 5-star rating. I actually think there's more likely to be that kind of kindness bias in this system than the opposite, but we'll see, and that's why I want to trial it. I want to give patients more kind of genuine power in this system, and choice, convenience, ease, like those are all sorts of things that patients will get through the app. They will feel an improvement to their experience, but I also want to give patients more bite.
On the app, a huge amount relies on digital transformation in terms of driving productivity improvements. The 10-year plan talks about bringing the NHS into the digital age. Who will be accountable for the digital transformation? Who will lead the digital transformation? Will the functions that were NHS Digital in NHS England transition to DH? Will resources maintain the same at that function?
Yeah, Jim, do you want to say more about
Yes, so we're working through that currently. The current plan is they will transfer as functions and be into the transfer into the DHSC.
Are they equally resourced as they are now?
Well, everything is subject to the cost reduction that's already been announced.
How will we do more? How will we drive a digital NHS if we see less staff working in digital functions? I think we've heard ICBs also reducing headcounts by 50%. Providers are often discussed as potentially leading digital transformation, but many of them are being pushed to deliver more frontline staffing, and usually digital isn't considered as frontline staffing. I think the business committee recently heard a session about NHS Digital. Around 3% of staff in the whole health service are in digital functions. Do you imagine that that 3% across central, regional and local systems will go up, will stay the same?
So everything is going to have to be challenged. There isn't part of the health service we can say you're absolutely 100% protected from a cost-saving point of view, given the overall position. We absolutely want to be sensitive and understand need and not shrink something when it actually is going to disable capability and capacity going forward. We also know that there's huge variation right across the system in terms of what people are currently investing in all of this. So the short answer is we can either say it's a straight 50% everywhere, or those things are completely protected, because it's just much more complicated than that.
And we've got, don't forget, we've got £10 billion has been allocated in the spending review.
Which is really welcome, but in terms of delivering that capital investment, if staff in the NHS are cut dramatically at all levels to roll out that capital spending, are you not worried that we might see more poor private sector contracting for digital products, more reliance on contracting and failed IT projects of old?
I wouldn't anticipate staff in this area being cut dramatically in the way that you suggest. I think Jim is absolutely right. In terms of the design of the new organisation, we want to reduce overall headcount by 50%. That's not the same as taking 50% out of every team and function. And clearly this is an area that is absolutely critical from a health security point of view, system delivery point of view, and future transformation point of view.
Thank you so much, Secretary of State.
Thank you, Danny. And can I go straight over to Andrew, please?
Thank you very much. I want you to succeed. I want this to succeed. The values are unarguable. I think the shifts
make a lot of sense. I mean, no one would argue that we need to shift from prevention to sickness, and therefore, we want the process to succeed. In the case of shifting from hospital to community, I just wonder whether, well, the question is how, and it's like changing the wheels on a moving bus, really. I mean, how can you do that when at present we know there is the pervasive problem of corridor care, of ambulances queuing, of avoidable deaths in emergency departments as a result of the pressures at that level? I mean, how can you take resources away, which is, I think, is in effect what you're proposing, whilst also making sure that the services are stable enough? Don't you need to double run to a certain extent?
So the two problems you describe are inextricably linked. And so, what we'll be doing over time is driving the left shift, not just in terms of transfer of resources, but also transfer of responsibilities. So there are lots of things from diagnostic tests and scans through to minor injuries and urgent treatment that can and should be done in primary and community care, as far as I'm concerned. There are also areas where we can and should make savings in hospital care, particularly in terms of outpatient appointments, where we want to significantly reduce the pointless activity that takes place in outpatients, and also to deliver more outpatient care where it is needed, to make sure it's delivered close to people's homes or indeed in people's homes, which will be more easy and convenient. I mean, we're only a year in, but we have already started to signal what that shift looks like, with £889 million into the GP contract, the employment of additional 1,900 GPs. We are beginning that left shift. It is going to take time, and one of the virtues of having a 10-year plan is you do these things in a managed and orderly way, rather than a disruptive and, worse still, self-defeating or destructive kind of way.
And you believe that it's possible in relation to the emergency entrance into the hospital, which is the one which I was referring to.
Yeah.
You're content that can be managed, and the crisis, we have to call it a crisis, it's still a crisis. It's not your fault. You've inherited it. It's a difficult one to overcome, but you think that we can get on top of that at the same time as you're doing everything else.
Well, there are lots of people who are presenting in emergency care who do not require emergency care, and I don't criticise those patients, because often it's the only place they feel they can access. But there are lots of things that the NHS is doing that, if rolled out consistently, would make a massive difference. For example, hear and treat services, when people are phoning up for an ambulance, being triaged on the phone, and often, as I saw actually with Jim's predecessor, Amanda Pritchard, up in the northeast on Teesside, instead of waiting hours for an ambulance that, when it turns up, is probably a little bit grumpy, even if they don't show it, because they think you didn't need to see me, someone else could have done this. They had a community response car out from the community-based team, much faster, so better experience for patients, but also better use of taxpayers' money. So I think the more we can get people the right care in the right place at the right time, the less likely they are to unnecessarily and avoidably call on emergency services, which then frees up those emergency services to do the things that only they can do. Finally, since you mentioned corridor care, I just wanted to inform the committee that we are shortly going to be publishing data on the number of corridor care beds, because I think sunlight is the best disinfectant, and we have to be honest about the scale of the challenge, so that you can hold me to account for improving the situation, and I can hold the system to account for improving the situation.
That's helpful. Moving it on, and we'll monitor that as time goes on. Moving on, you mentioned that patients can be treated, and you've dealt with a number of cases where they've been treated egregiously, I think was the term that you used. To what extent? I mean, I'm looking at chapter 7 of the document. To what extent do you think that there needs to be more in relation to mandated safe staffing levels? I mean, for example, we know that beneath all of the the heat and fury of the mid-staff's inquiry reports was chronic, unsafe staffing levels in many of those contexts. So to what extent do you think that there needs to be established, mandated, registered clinician staffing levels?
I'd say a few things and bring in Jim as well, and Sally. So firstly, when it comes to thinking about quality and safety, kind of mid-staffs looms large in my mind, and the lessons of that inquiry, and also the conversations I've had with a significant number of families over the last 12 months, which have been by far and away the best and worst meetings I have sat through, best in terms of the insight, worst in terms of how harrowing and distressing some of the stories I've heard have been. I think there are lots of things, lots of tools we have available to us now which we didn't have when we were last in government, in terms of the quality of the data that's available, how we can use that to do much better early warning where things are going wrong, or where you can see patterns in patient experience that might point to a deeper problem and you might want to send the team in. Mm-hmm. We are also, thanks to the work of Penny Dash, looking to streamline regulation so that the people who are regulated know the rules that they're working to and can discharge safer care because they've got much clearer marching orders, and we can better assess their performance against those, reforming the CQC. So there are a whole number of things we can do on quality. On safe staffing levels, I think it's really important that we work with the professions and look at each clinical pathway and look at what safe staffing levels mean in each case, at the same time as recognising that this isn't going to be static. There are all sorts of improvements in medical science, technology. There are a growing number of roles, and obviously we are doing a bit of first principles thinking on that at the moment, and we'll be publishing the Lang Review shortly in relation to medical associate roles, for example. But I think we have to kind of make sure we're, by all means, discussing and debating safe staffing levels, but following the evidence as we do so as well.
If I may move on just to one area where I think safe staffing is important, and that is nurses. And you mentioned that earlier, and you've heard the RCN were talking about their pay and conditions today. And obviously I know that, Sally, you come from a nursing background yourself, that very often you'll have people who go into nursing who commit their whole careers to it and finish on band 5, which can be at the top of the spine at £37,000. I mean, someone who's committed their lives to that profession and to end up at that level. Do you think that is sufficient? The majority of them, end up in that situation. I mean, in Chapter 7 you talk about recruitment and how to recruit, but it's retaining nurses is the big problem. I mean, they're leaving in their droves, and no wonder.
Yeah, that's right. And I'm anxious about this. I don't think our nursing profession have received the level of respect and support to which they are entitled, and unless we give nurses better job security, better job satisfaction, and unless they feel genuinely recognised and rewarded for the work they're doing, we end up, in the worst of all worlds, of investing a lot in their training and then losing all of that knowledge and experience when they go elsewhere. And we are working, in fact the Chief Nursing Officer for England is working with the professions to develop a strategy that will make nursing and midwifery modern careers of choice to address the decline in applications to education programmes. And we have committed to RCN, Unison and others reform of the Agenda for Change structure, which I think would make a real difference. And we also want to see opportunities like consultant nurses, nurses as leaders in their own right. So I think the future for the profession is bright, but as with most things in this job, going back to July 2024, not necessarily where I would have wanted to start from.
No, of course. And, I mean, that's all in the report. But just final question.
Andrew, it's 37. You've got a minute.
Okay. Final question. In my area, the social care contracts, both NHS and the local authority, are proposing to pay social care workers £12.79 an hour, irrespective of whether it be holiday, unsocial hours, or any other. I mean, we know that the national living wage is £2.21.
Andrew, ask your question.
How can we possibly fill those contracts when the service itself isn't prepared to pay for it?
It is the thing that unites the employers, the trade unions, and the local authorities. Unless we pay our care staff better, and unless we build a genuine social care profession, we are going to fail to recruit and retain the brilliant people we need. That's why fair pay agreements were introduced on the face of the Employment Rights Bill in the first 100 days. That's making its way through Parliament, and Deputy Prime Minister and I will shortly be setting out how they're going to work in practice and the funding attached to it.
Place to stop there, please, Wes. Can I go straight over? Thank you, Andrew. And can I go straight over to Josh? Thank you.
Thank you, Secretary of State. I'm going to talk a bit about the kind of career progression of doctors and kind of training routes, if that's okay. So in 2012, 66% of doctors who completed foundation training, so F2, would go straight on to a specialty training programme. That's shifted to now it's 22%. Obviously that's a huge shift in the medical workforce, and some of that is driven by the fact we don't have enough training places. You've said you're going to get 1,000 new training places over 3 years. Is that enough?
Yes, if I can go further, I'd like to. I mean, notwithstanding, I don't agree with the BMA about the timing of their proposed strike action or the necessity of their proposed strike action, but not just the concern, the anger and frustration that I hear from resident doctors, I absolutely share. And as I've said to many of them, the best pay rise that they can get is going from being a resident doctor to a consultant. That if we can deal with the bottlenecks issue, that will be better for them, better for patients and the NHS, because we need more of that clinical leadership capability.
So we're now also seeing just a massive increase in the number of doctors going on to SAS and LE contracts. Is the answer to that a more formal role for SAS and LE doctors, or is it to get training sorted and to get other routes onto the medical register?
No, I think you're right. We've got our workforce plan that we're currently developing in light of the 10-year plan. The previous workforce plan just wasn't in the right place. A number of its assumptions were flawed. If we continued the rate of growth that the long-term workforce plan had assumed, then by the end of the century 100% of our population would need to work in the NHS. I think we can all agree is implausible, to say something else then. And so therefore we are developing a workforce plan that aligns with the strategic direction set out by the 10-year plan. And I think that also offers us an opportunity to deal with some of these thorny issues that just haven't been dealt with and have led to resentment in the profession. Sally? Oh, sorry.
I mean, I get that, but I'm just trying to work out kind of what does our doctor population look like? Because I mean, we all know that resident doctors deliver most of the care, as do SAS and LE doctors. So what does it look like? Are we going to have a greater proportion of SAS and LE doctors, or are we going to get the SAS and LE doctors into formal programmes through to being kind of at a higher level of training and being...
You're tempting me to preempt the workforce plan. But those are exactly the sorts of questions we need to address. Yeah. It's like the size, the shape, the capacity, the capability of the future workforce.
Yeah. There was a brief mention in the 10-year plan about simplifying routes for SAS and LE doctors onto the medical register. I think last year 276 doctors went through what used to be the CSER-SEGPA route. Is that the right kind of number, or do you think that we should make it easier for SAS doctors to become?
We do need to make it easier and simpler, and again, that's something we'll be looking at in the context of the workforce plan. I mean, we also need to look carefully at the diversity of the medical workforce. And I don't just mean doctors, but if we take medicine specifically, it is still the case that too many people who are signing on to medicine course at university are from the sort of backgrounds of sons and daughters of doctors, and we do need to make access to medicine more open to working class students from backgrounds like mine, and not just to preserve of people who can afford it. And similarly, thinking about the broader NHS workforce, one of the great tragedies, particularly in nursing and midwifery, is a lot of people who've reached a stage in their life where they might have a career change. Maybe they've been doing some caring for younger relatives or older relatives. Think I'm now going to go into nursing, or I'm going to go into midwifery. They're not doing it. So we've got to deal with some of these disincentives, because we're losing a lot of people with really valuable life experience from going into a whole range of NHS professions.
Do you think part of that, some of the assumptions baked into NHS contracts? So 60% of doctors who've just qualified are women, which is compared to a medical workforce where they make about 49%, so you can tell like it's kind of skewed younger. Is that just because it's not flexible enough?
Yeah, and I was thinking back to the big row that Jeremy Hunt had with the BMA over 7-day working. And that argument looks so kind of dated now, because I think lots of people, not just in the NHS, but particularly in the NHS, would like more flexible working. And one of the reasons why we've seen agency costs shoot up is because people have seen kind of agency work as the only way to get a career that fits around their lives. And that's worse for them, because they don't necessarily know where they're going to be working from one place or 1 week to the next. And you don't build that sense of camaraderie and teamwork and relationships at work that I think we all value most of the time. It's also not great for the NHS that ends up paying through the nose, or for patients who might not have that kind of continuity, even in a hospital setting where you get to know the clinical team around you. So I think flexible working is a win-win. And again, in contrast to the sort of approach we've seen in the past, I don't think this is something that we need to impose. I think this is something that we need to offer. And I think we'll find staff taking it up in a way that benefits them, benefits the NHS, and most importantly benefits patients.
Do we need better flexible training as well? Because actually, if you think about the point of life at which doctors are in specialty training, and given the majority of women, does training need to be more flexible?
Yeah, I think we do need to look at that. And we also need to make sure that training for all parts of the NHS workforce in all cases is valuable. There's a lot of complaining from NHS staff who feel like they are kind of subjected to a whole load of training that they feel is pointless. And this sort of kind of brings to life really why the idea that NHS staff are opposed to reform is nonsense, or that they're somehow a problem on productivity is a nonsense. Because actually one of the things that staff really complain about in terms of training they're subjected to that they think is pointless is they want to be out seeing their patients, and they know that their time away from clinical practice is valuable time. And so, we've got to make sure that we're using their time effectively and asking them to do things they need to do, genuinely need to do, or offering them development opportunities where we can, rather than subjecting people to training they think is a pointless waste of their time.
And how are we going to make sure we've got people in the roles that we need for the future? Because obviously it's much easier to train a doctor into the specialties that we have at the moment, and the specialties where we have more people. But actually, if we're going to have more people, GP training is a particularly difficult one to train the right number. How are we going to incentivise that, and how are we going to get that shift?
Yeah, we do need to look at all of the training routes to make sure that they are relevant to what modern clinical practice will look like, and the way in which these roles are going to evolve with medical science and technology. And we've also, I think, part of the challenge with general practice and with district nursing, for example, they've not had the best rep with medical students when thinking about where they're going, or nursing students when thinking about like what they imagine their nursing career to look like, because they've been seen as on the slide or going through a bad time. So if you're reading all the time in the newspapers that GPs are overworked and burned out, and constantly seeing GPs given a kicking because people can't get an appointment, you're not going to think, oh, do you know what, that's where I want to go to work. Or similarly, with district nursing, there's been a sense for some time that that part of the profession has sort of been on the wane. And actually, the pitch I want to make to the doctors and nurses of the future, as well as other allied health professionals, is that like community neighbourhood health is where it's at. It's where some of the most exciting medicine will be practiced. It's where you can make the most difference to patients in tackling health inequalities. And I think that will really speak to the values of the generation that's coming through and what they want to achieve. So I hope that we'll see a kind of a good deal of enthusiasm for working in general practice or working in community teams as district nurses and all sorts of other roles.
One final question, Secretary of State, and it's a bit from left field, but you said community and neighbourhood health is where it's at. Earlier you said social care will be the kind of the door out of the NHS. We've talked a bit about funding, but actually, like, this report is brilliant, but it is very light on social care, and it points just to the result of the upcoming Casey review. I don't feel that it grasps the nettle quite. Do you? If you would you like to see it grasp the nettle more, and how can we be confident that between now and the release of the Casey review, social care is going to be in a better position?
Yeah, well, without reeling off the list I gave earlier, I think things we've done in the first year of this Labour government have been significant and substantial on social care. But I recognise it's against the backdrop of much wider kind of challenge and crisis in the social care system. What you'll see next year from Casey is a kind of set of recommendations and effectively marching orders, because it's Louise Casey, about what we should do for the remainder of this Parliament, and then the long-term reform agenda, which I think involves a much wider national conversation about what we need from social care, how we fund it. That will come following that. So it's not like there won't be other big things going on in social care between now and then. I mean, what we're doing on fair pay agreements is in itself a significant reform.
So
but I do understand.
I don't really know about fair pay agreements. I'm not sure if this is...
Josh.
We'll come back to you on that.
Thank you, Josh. Can I go over, these are snap questions, snap answers we're asking for. So, Greg,
answers
over to
I'm
you.
least good at.
Well, yes, unfortunately, I doubt you're going to be able to do this in the snap answer, but I look forward to writing to me. Sir Jim, in an answer to me earlier, the Secretary of State suggested that he didn't see it being the role of resident doctors to be involved in productivity and efficiency. Is that your take on this, or is there a role for resident doctors in any part of the workforce to be part of that?
I don't think he said that. I think he said we shouldn't blame resident doctors for the productivity problems that the NHS has got. So we've all got a part to play, and our approach to productivity will look at things in the round, the workforce, technology, the estate, etc. All that's in hand. But I don't think he actually said what you just said.
If I've mischaracterised him, then I apologise. But specifically, then, where do you see the workforce playing its role in efficiency and productivity?
So we want the whole of the workforce to engage in the challenge that we've got. We've got a finite amount of money that's on the edge of what the economy can afford. It's a huge growth over recent years, and we've got lots of patients to treat. So we need everybody to lean in and participate in the innovation, the transformation, the pathway changes that we've all got to play. And it's not possible by just the management system pushing it or certain parts of the clinical community pushing it. We've got to try and do it all together.
The best examples of improved productivity in electives, for example, has come from clinical leadership.
I agree.
And frontline clinical leadership. And obviously that includes resident doctors and other NHS staff. So that's what gives me hope actually about the future. I think they are up for the challenge. They want us to kind of take the brakes off.
You would cite an example, maybe the GIRF programme.
Yeah, it's very good.
Very much.
Becky, you came next.
Thank you. You want a snap question, Chair?
Snap question, snap answer. Great stuff.
So gambling, Secretary of State. It's currently in DCMS. there is an increasing evidence base that it is incredibly harmful, particularly the more dangerous products online. What do you think about seriously putting it into the Department of Health and looking at it as an addictive, harmful agenda as opposed to an entertainment agenda?
Yeah. I think gambling's a bit like alcohol in that I don't want to stop people from having a flutter. I don't want to stop people enjoying a pint. But in both alcohol harms and gambling harms, what you see are a minority, but not insignificant number of people who experience severe harm. And
just
that's
pressing
where we've got
you wouldn't
to
put
focus.
alcohol in DCMS. Why would you transfer gambling on that? The logic of your argument?
Well, alcohol policy it sort of straddles us and the Home Office, and I think in terms of gambling harms, I have a kind of line of sight into it as the Health and Social Care Secretary, but it sits with DCMS.
For now, thank you, Secretary of State.
Thank you, and Danny, over to you.
Thank you. The committee's looked at child vaccination rates recently. We had a tragic case, an outbreak in the last few days around Alderhay. The 2012 outbreak in Merseyside cost £4.4 million to treat, 20 times the cost of the vaccinations that would have prevented it. The 95% WHO target has not been met. The rates between areas vary, sometimes 30% in vaccination rates. Was it right to downgrade the 95% target? Should it be restored for the system? And are we doing enough to increase child vaccination rates?
I mean, firstly, no child in this country should be dying of measles, and I'm extremely sorry to the poor family that's now grieving the loss of a child in those circumstances. I'm sure everyone will join me in sharing condolences. This is why we have got to redouble our efforts on vaccination and to make the case. And some of the improvements in the 10-year plan will help in terms of having digital records of children's health that parents can check into, the digital red book. That'll be really good. So it means that on moments like, you know, over the weekend where someone's read an awful case in the media, parents can just quickly log on and think, actually, did we get that jab? Are we up to date on our vaccinations? And we can also proactively invite people to vaccination. But we'll be doing a lot more on this throughout the remainder of the year in terms of trying to get vaccination uptake because it saves lives.
We need additional investment and support to get those areas that are 30% below the highest levels of vaccination in the country up to where they should be.
And we do have significant resource already attached to public health information campaigns. What I will do is write to the committee, sort of given the profile of this issue at the moment, to share the work that we'll be doing to drive up vaccination rates. Jim, is there anything you wanted to add?
No, thank you for that, Danny. Thank you for that. Can I hand over to Ben?
Yes, thank you.
Fire question.
Yeah, the 10-year plan has some dates for when things will happen by. Are you planning to produce a single overview timetable for implementing all the different promises in the plan? And if you are, when will you produce that timetable by?
There are lots of dates throughout the plan. You know, what we can be clear about is what we're doing over the next few years, because that's in the spending review period. Obviously, you know, from one year to the next, you have to revise your financial planning. But overall, we've got a clear set of commitments for the next few years, which is the sort of clear line of sight that I have in terms of the money. Beyond that, you know, we're kind of more into ambition territory. For no other reason than I'm really reluctant to make promises with, or to indeed to write checks without knowing that I can cash them.
Absolutely right. So could you at least pull together everything that's there as a date at the moment and produce a single timetable? It would just be easier for us to deal with and probably everybody else out there as well. Would that be possible?
It's possible, Jim.
So what we're planning on doing is have the NHS produce medium-term plans in the round in the autumn, start in the autumn and complete by Christmas ideally. So that will set out how the NHS takes this plan and all of our other operational imperatives and plan that over a period of time.
It's going to be one of those NHS, I mean, I've sat on an ICB for 2 years. Is it going to be a nice, simple 2-pager that we can all read as well as the 350 pages that an ICB would usually require us to plough through?
Hopefully, yeah.
Yeah? Just a couple of pages.
All right.
Thank you.
Thank you, Ben. Andrew, over to you.
It's a lot of homework.
So you made the patient voice a very high priority for you, and not just in terms of patient power and in your introductory remarks, but you're scrapping Health Watch. So what are you going to be putting in its place or to ensure that there's an independent vehicle to ensure that the patient voice can be heard?
So I'd say a few things about that. I mean, firstly, I don't doubt for a moment that Health Watch and Health Watches across the country have produced some valuable work over their time. But we're moving into a new phase where patient voice should be embedded throughout the whole system. There are other national organisations in this space, but fundamentally we want to give more power to the patient. Secondly, I'd say as parliamentarians, we've got to stop outsourcing our job to other people. Like, government is doing it all the time with the proliferation of loads of arm's length bodies that basically say either this is too difficult and too controversial, we don't want to touch it, so we're pushing it out over there, or we don't trust ourselves as politicians, so it's going over there. And the same is true for advocacy for the public. We shouldn't need loads of organisations to speak up on behalf of our residents and citizens. That's our job as parliamentarians and councillors and elected representatives.
Thank you, Andrew. Thank you. Over to me. My last question is about black maternal health. I am passionate about this subject, as you know, Secretary of State. The fact that 3.7 more black women are having poorer outcomes than white women is an issue out there. They've talked about this national maternity investigation. Yeah. Using the 10-year plan, how are you hoping to address some of these issues? If the question is too much for today, I'm happy for you to write in.
The first thing I want to do is just reaffirm to you and to the committee that we will have a target in this area for improving the mortality gap, because I think it is so important. And as you know, I'm trying to reduce the number of targets overall, but I think this is extremely important and morally impossible to sort of justify this gap. As part of the national investigation and the work of the task force, we are going to make sure that the inequalities side of maternity failures is absolutely integral to the work that the investigation and then the work of that the task force does. So we'll definitely be coming back to this topic, I know, but I want to reassure you and the committee that the racial inequalities in maternity care and failures in maternity care is going to be absolutely at the heart of the agenda. If we can't get tackling racial inequalities right on maternity, then I don't think we've got a chance of doing it in the rest of the NHS.
Right, can I thank you for that? The 10-year plan will be a topic that we will absolutely be returning to in our future sessions, and we will be hoping that you and your ministers will be able to return to the committee to answer questions, Secretary of State. And also we're really looking forward to having Jim Mackey in September to go through the ICB reforms and finances in more detail.
Like Jim.
So I think we've been pussycats. On that note, can I say thank you all for coming, and you've done a great job in a short space of time, and the committee. Order.